visit for 2 weeks. But that's the predicament that we are in. So today we are going to do our review for block 3. And I know I'm not even the nearest one on the horizon, but the biggest one on the horizon. So I imagine most of you will look at this later when our test is the next one on the horizon. But we'll go through it together, and we'll talk about the important things that we're going to talk about, or for the you're going to be tested on for the test. For Friday's lab, it's not going to take 4 hours. It may only be about an hour and a half at most. And we will be meeting in a group here in the classroom. So the whole class will meet here, and we're going to just run through some cases working with the heart failure algorithms on applying a patient scenario to those algorithms and how to use them, work with them, and everything. So we'll meet here for that lab. All right. So let's start with our review. And our first lecture was talking about valvular heart disease. And it's important to know what makes it a regurgitation and what makes it a stenosis and the murmurs that are associated with it. So regurgitation is due to the valve leaflets not sealing for some reason, and now blood is leaking in the wrong direction. And then stenosis is usually like a thickened fibrotic valve where it's resistant to opening. If you aren't sure which ones are systolic murmurs, there are some acronyms to help you with that. And then there's diastolic murmurs as well, and an acronym to help you recall which ones are which. When we talk about murmurs, there is a grading scale to it. And this is important because on the next slide, when we start talking about what makes something pathologic and what makes it most likely benign, one of the things that tends to make it pathologic is a loud murmur, where you have like a systolic murmur that's grade 3 or higher. That is a pathologic murmur, and what that's saying is that murmur is easily heard. 2 out of 6 is faint but immediately audible. So what's the difference between the 2 and the 3? That's a hard one to really discuss, but the definition says a grade 3 is easily heard. Other things that might make a murmur pathologic is if it's diastolic. All diastolic murmurs are pathologic. All pansystolic or holosystolic murmurs are pathologic. A continuous murmur and late systolic murmurs are also pathologic. So knowing that all of those are pathologic, the next step, if you appreciate any of these, is give an echo. Okay. So that's really for this flow chart, really all I want you to know is what makes a murmur pathologic and what's the next step. Okay. Then we went on and we started talking about the kind of the spectrum of streptococcal infections, where a kid having acute strep pharyngitis, especially if it goes untreated, can or is at risk for 2 to 3 weeks, or in 2 or 3 weeks, to develop acute rheumatic fever. And then, unfortunately, somebody who has developed acute rheumatic fever then is decades down the road at risk of developing a rheumatic heart disease, which is a permanent damage to heart structures that oftentimes requires further interventions or increases morbidity and mortality. When we talk about acute rheumatic fever, so they have had a group A streptococcal infection, and then typically 2 to 3 weeks later they develop this syndrome, and it causes damage to the leaflets, particularly the mitral valve being the most common, with the aortic and tricuspid falling behind that. But it tends to be globally a huge burden on our healthcare system because when you live in a country that doesn't have access to healthcare, doesn't have access to good antibiotics to treat group A strep, then that population is going to be at much higher risk of developing this condition. You can see globally the incidence is 19 for every 100,000, but in the US, and I would say that this value is pretty similar to other industrialized nations, you can see it's much, much less. The age of the population that's going to get acute rheumatic fever is going to be your pediatric young adolescent population, because this is the age that is the highest risk of getting strep throat. Okay. And then the biggest thing that you can do to prevent the onset of acute rheumatic fever is to treat strep throat with antibiotics. So if you treat it, the chances, the risk of developing acute rheumatic fever are essentially zero. But if untreated, then there's a 3% risk that that patient is going to develop acute rheumatic fever. When somebody presents with acute rheumatic fever, there are kind of the vague kind of symptoms, fevers, chills, not very specific to this condition. But the Jones criteria really can point towards this patient having acute rheumatic fever. And when we talk about acute rheumatic fever, there are the major criteria and the minor criteria. But one of the key things that you have to remember is that there is a history of strep infection, or at least I can show that there was a strep infection recently. If you can't prove that, then Jones criteria doesn't really suffice for our patients. But if you can show they would have that strep infection, then you either get two major criteria to be officially diagnosed with acute rheumatic fever, or you can get one major and two minor. When we talk about the major criteria, again, the acronym Jones actually helps you recall what the symptoms are. So the J stands for joints, which is a migratory polyarthritis that typically affects the large joints. So this is not a little joint kind of disease. This is not like gout that tends to affect like the big toe. And it's going to be the major large joints that get this. The heart, or in the O in Jones, is carditis, which is the second most common symptom that your patients are going to experience. The joint, the arthritis is the largest, most prevalent in our patients with acute rheumatic fever. But carditis is the second most. And this is because of that autoimmune cross-reactivity between the streptococcal antigen and cardiac antigen. So it's an autoimmune reaction that occurs and causes this. And it can present with a lot of different cardiac effects. So it could be tachycardia, which can come from a number of things, including the infection itself, but also from just kind of that compensatory mechanism of that cardiac output dropping because of things like reflux, regurgitation rumors, and the cardiac output dropping, so it's got to speed up in order to counteract that. You may have impaired ventricular contractility, so it's not contracting as strong as it should. And because this is an inflammatory reaction, you could get a pericarditis component to this as well. And then it's going to sound, you may hear that friction rub from the pericarditis. The N in Jones is subcutaneous nodules. This is the least common of the symptoms, but they typically will have this firm but painless nodule that affects some of the major joints like wrists, elbows, knees, and Achilles tendon. And then erythema marginatum is the second least common symptom, and usually you're going to get like this non-pruritic, non-painful eruption. It almost looks like a fungal infection, but the non-pruritic nature of it is not consistent with fungal, so it's actually part of this Jones criteria. And then the last major criteria for Jones is the Sydenham's chorea. So this is this rhythmic disorder, neurologic disorder, often described as like a tic. This is separated from a lot of other tic kind of disorders because it doesn't really occur during sleep. So when patients go to sleep, this stops. This is a self-limited symptom. This is not something that they're going to be having to deal with for the rest of their lives. It typically lasts only 3 to 6 weeks and then resolves on its own. And then for going back to proving that there was a strep infection, yes, you do have the typical things we use to test for acute streptococcal pharyngitis with like the throat culture or the rapid strep test. But there are the antibody tests that can use titers to prove an infection or a recent infection. And then if you still are not convinced or don't know exactly what's going on, you can do a cardiac biopsy. And if it is acute rheumatic fever, it's going to be described as Aschoff bodies being present on that biopsy sample. And then the way we treat it is we need to give them antibiotics to treat the bacteria that's there that's causing this. But then we also need an anti-inflammatory therapy, i.e. with aspirin, to kind of deal with that the inflammatory response that's occurring in that patient. And the aspirin doses, you don't necessarily need to memorize the dosing of this, but just recall that it is a high-dose aspirin therapy. It's not a small dose. It's not a baby aspirin and that's it. They're going to need to be on high doses of aspirin, including children. And then one of the big things to then recall from a prognosis and for additional treatment, for anybody who has acute rheumatic fever, the risk of them having another acute rheumatic fever in the setting of acute streptococcal pharyngitis is pretty high. So typically we think about doing like a prophylaxis therapy for them to prevent them from ever getting strep throat again. And this can be either a daily oral medication that they take or even a like monthly injection that they get. And it could last for 20 to 40 years, kind of depending on when they develop their acute rheumatic fever and also how severe their reaction was. Because any times that they get acute rheumatic fever puts them at risk of developing puts them at risk of developing rheumatic heart disease. But if they have subsequent infections, then you can imagine that the risk increases quite drastically that they will develop that permanent damage that you see a couple of decades down the road. Rheumatic heart disease, again, we said this is like 10 to 30 years down the road. And typically, the valves that are most commonly damaged are mitral is the most common, aortic is the second, and tricuspid is the third. And it may be either a stenotic or a regurgitation murmur that develops from this valvular damage. And we talked about rheumatic heart disease, even though we don't see it very commonly in the United States, because globally, like when we look at the specific valvular diseases, globally, the rheumatic fever heart disease is the most common cause of like mitral stenosis in the world. Now, in the United States, because we don't have as much of an incidence of this, this may take like a number 2, but globally, rheumatic fever heart disease is the most common cause of mitral stenosis. And when we talk about mitral stenosis, what's happening is because we have that resistance and to opening the valve during diastole to allow that passive flow of blood from the atria into the ventricle, what ends up happening is we get increased atrial pressures, which then translate and go back to the pulmonary system, which then increases the pressures and volumes in the pulmonary blood vessels, and that causes that fluid leak and leads to that pulmonary congestion that we see with this. And this can be made worse from other conditions developing, such as like arrhythmias, where like AFib, you lose that atrial kick. Now I'm losing the active component to diastole to get that flow of blood. So now I'm purely reliant on the passive flow, and that passive flow may not generate the pressures necessary to get that mitral valve open, or at least keep it open long enough to allow an adequate volume of blood to get into that left ventricle. So they're going to present with both pulmonary symptoms due to that congestion, so like the progressive dyspnea on exertion. They also will exhibit decreased cardiac output symptoms, so exertional symptoms, and then also right-sided heart failure kind of symptoms as well, so the peripheral edema, the jugular venous distension, and those types of things. And then when we talk about the specific murmur that you see with mitral stenosis, remember it's this decrescendo crescendo pattern, and what causes that crescendo pattern, the getting louder part to it, is that atrial kick, where you get the squeeze of the atria, it generates that higher pressure differential, and now you get that turbulent flow increasing as you generate that squeeze. But because this is a mitral murmur, or mitral valve disorder, it is best heard at the apex of the heart, so in the mitral auscultation site. Looking at some ancillary tests that we can do for mitral stenosis, because this affects the left atria but doesn't really affect the left ventricle, because the left ventricle itself is not diseased, it's the valve that's diseased. You'll see this isolated like left atrial enlargement without the left ventricular hypertrophy. You may see the right side being impacted depending on what's going on in the lungs, those pressures, and how that translates over to the right side of the heart. But you'll see there is no LVH listed under mitral stenosis by itself. And the test of choice, of course, is going to be the echocardiogram, because it's the best imaging study we have that looks at the valves themselves. And the classic finding that you see in mitral stenosis on echo is that fish mouth deformity of the mitral valve, where it's just that leaflet, those leaflets of the mitral valve are thickened, calcified, and stuff, and it looks like a fish mouth. How do you treat it? Well, we got that volume overload issue going on, so let's limit that volume overload by doing things like salt restriction and diuretics to help with that. And then we can do beta blockers or the non-dihydropyridine calcium channel blockers. By slowing the heart rate down, we're going to increase that diastolic filling time, so hopefully we can get a little more volume in the left ventricle before systole starts. And then if they have issues with rate control, like an AFib, then digoxin. And then, of course, anticoagulants is always an important consideration if you have static blood flow or other arrhythmias that can cause stasis, which puts the patient at risk of developing clots, which can get thrown anywhere in the arterial system if it's there on the left. And then the way we typically treat this, we would prefer to do a percutaneous mitral balloon valvotomy, where they basically put the balloon, inflate it, and it pops open that leaflet. There are risk factors for it, but if they're not a candidate for the balloon valvotomy, then we can do a heart valve replacement. And there's two choices that we have for that. We have the biologics, which use like human cadaver or pig or some other animal source, or we could do a mechanical, which is typically a synthetic material like carbon fiber or those kinds of things that tend to last much longer. Especially when you compare mechanical valve of at least 20 years, comparing that to the biologic, which is maybe 15 years at most. If you need that longer duration, then a mechanical valve would be warranted. But understanding that somebody who gets a mechanical valve will then have to be on lifelong anticoagulation, compared to a biologic where you don't need anticoagulation because it's not a prothrombotic environment in that case. So just recall which one has the longer lifespan and which one requires anticoagulation, so you can understand when you might want to use one over the other. Then we started talking about mitral regurgitation, and when we talk about any regurgitation valvular disease, we have to talk about what makes it primary and what makes it secondary, and then we have to talk about what is acute and what is chronic, because the treatments are going to be different depending on if this is primary, secondary, and if this is acute or if this is chronic. So when we talk about primary mitral regurg, so primary means there's a problem with the valve components itself. So the valve leaflets are the problem, or let's say the chordae tendineae, there's something wrong with that that's causing the valve leaflet not to function properly. And there's a number of ways, or a number of things that can cause a primary mitral regurg. Mitral valve prolapse is the most common one in the United States, but other things like infective endocarditis, where you have like an eating away of the valve, and so now you have a hole there, that can lead that. Trauma, rheumatic heart disease can be a primary source for this, because there's a damage done to the valve components itself. Secondary mitral regurg, typically there's things outside of the valve leaflets or the valvular, components that leads to this. And one of the best things, or most common ways that you see this, is if you get like a dilation of the ventricle, it pulls those leaflets apart, so now you can't get that seal to provide that one directional flow. So then you have that regurgitation going back to the atria. And things like this would be like the left ventricular enlargement, hypertrophy. It could be acute myocardial infarction, where now the structures are not functioning like they should. And then when we talk about the consequences, the pathophysiologic consequences of this, what ends up happening because of that regurgitation of flow going from the ventricle to the atria, now you're going to have this higher volume and this higher pressure in the left atria. You're going to lose cardiac output because a lot of the preload is now going in the wrong direction. And then you tend to also then have all these volume-related stress where now the ventricle is dilating, or it's having a hypertrophy to try to generate a higher squeeze to try to generate a larger cardiac output, but unfortunately it just makes this situation worse. From a pathophysiologic standpoint, if you have acute mitral regurg, things like rupture of an infarcted papillary muscle, rupture of the chordae tendineae, blunt chest trauma, you can imagine this acute kind of onset, the body can't compensate for this condition, and they tend to be pretty sick, in critical condition pretty quickly. If we have chronic, this is going to take time for these conditions to develop that lead to these problems. So that means that we have time for the heart to kind of adapt and develop compensatory changes to deal with this. So things that take a long time are going to be causing chronic mitral regurg. And the pathophysiologic changes that we see is in the acute, because of that quick rise in pressure, quick rise in volume, that's going to quickly translate to the pulmonary circulation, which is going to lead to pulmonary congestion and edema. So they're going to have those pulmonary symptoms pretty rapidly. But then also you're going to have that rapid onset of decreased cardiac output. So now they're going to be symptomatic of heart failure. From a chronic mitral regurg standpoint, you're going to adapt, so the left atria is going to be a little more compliant. It's going to be able to handle a larger volume before that pressure starts to rise. So you're going to see a delay in that pressure and volume getting translated up to the pulmonary system. So folks with chronic mitral regurg tend to be more symptomatic due to the decreased cardiac output than they are from that regurgitant flow up into the atria and affecting the lungs. So think like left-sided heart failure as the primary symptoms that you see with chronic mitral regurg. And when we talk about mitral regurgitation, the mitral valve should be closed during systole, so this is going to be a systolic dysfunction. We can typically think of this as like a holosystolic. There may be instances where you have an early to mid-systolic, but holosystolic is typical of like your chronic mitral regurg. And it gets worse with like hand grip, because what you're doing is you're increasing the afterload, so now you have an even higher resistance to get flow of blood out of the ventricle and into the aorta, so it's going to want to back up into the atria instead. So that's going to make doing the hand grip dynamic maneuver is going to increase the intensity of this murmur. And then a key thing is it also tends to radiate to the left axilla, and that's because that flow of blood, because of how the heart's twisted and tilted, that direction of flow, that regurgitation flow, is to the left axilla. Now with mitral regurgitation on the EKG, you're going to see that left atrial enlargement, but because the left ventricle is also being affected by this condition, you're going to see those compensatory changes also on the EKG of the ventricle. So you're going to see that left ventricular hypertrophy present with this. Echocardiogram is going to be your test of choice, because you're going to see all the compensatory changes and the damage and the functional limitations from this, but you're also going to be able to see and measure the degree of volume that is regurgitating through that valve. And then it also may give you an idea of if this is primary or if this is secondary mitral regurg as well. In the acute setting, we're going to quickly try to reduce their afterload by giving them things like nitroprusside, or we may need to do some things to help with that, help increase that forward cardiac output, things like the intra-aortic balloon pump. But ultimately, these folks are going to need some type of valve repair or replacement to correct this condition. If it's chronic, then for primary causes, then we're going to do that valve repair replacement, because the valve components are the problem in primary causes, right? But for secondary causes, we're going to find out what that secondary cause and address that. Let's decrease that dilation, that ventricular dilation that's occurring in our HFrEF or in our dilated cardiomyopathy or whatever that's causing those valve leaflets not to seal and close properly. Then we went on, we started talking about mitral valve prolapse, and we talked about how the prolapse is just the hypermobility of the mitral valve leaflets, where it billows backwards into the atria at least 2 millimeters. And sometimes, though, that movement, that hyperelasticity of that valve leaflet can then lead to a regurgitation, and then you hear a regurgitation murmur associated with it. But not everybody with mitral valve prolapse is going to have the regurgitation component to it. And then typically, this is probably one of the more common valvular diseases that you're going to encounter in our population. About 2% of Americans have this, and it tends to be much more common in women than men. And then we said that with mitral valve prolapse, the vast majority of patients tend to be completely asymptomatic, have no idea that this is going on. We may just hear those clicking or that regurgitation murmur on auscultation when they come in for their physical. But there are some dynamic maneuvers that you can do that actually will affect the timing of the murmur and the intensity of it. So if I decrease my preload, the murmur, the click occurs earlier in systole, and it lengthens the murmur. If I increase the venous return, it delays the click and shortens the murmur. And kind of think of this, the cause of this is what's that preload, and how is that putting tension on that valve leaflet, the chordae tendineae, to keep it closed, versus when it's squeezing to decrease the volume. you don't have much volume in there, so you're not putting as much tension on the chordae, so the valve leaflets are allowed to move excessively much earlier in systole. On your ancillary studies, don't rely on these to give you any diagnosis, especially if this patient is asymptomatic. Really, the only thing you can do is your echocardiogram, because you're going to be able to see that hypermobility of the valve leaflets. So you can measure DC to be able to see if it goes back at least 2 millimeters or more. And then you can also see with the Doppler part to see if there is any reflux present to that condition. And then the treatment for mitral valve prolapse often is just reassurance, don't need to do anything about it. But if they are having like severe regurgitation, then they meet the criteria of the regurgitation to see if they are surgical candidates or not. Then we went on and we started talking about the aortic valve. And we talked about how the aortic stenosis is the most common cardiac valve lesion that we're going to encounter in the United States. So we said mitral stenosis in the world, but in the United States it's aortic stenosis. And the most common cause is a congenital bicuspid valve. So instead of having those 3 leaflets, you only have 2 because 2 of those leaflets are kind of fused together. And it's common in about 1 to 2% of the population. So almost as common as mitral valve prolapse is. And because this is something you're born with, folks who develop aortic stenosis prior to the age of 70 are probably at higher risk that this is the cause of their condition. But you can have other etiologies of this being basically like atherosclerotic disease, wear and tear, where you get the calcifications that then leads to the fusing of those leaflets. And then rheumatic heart disease is the most common cause of aortic stenosis worldwide, but the 3rd most common in the United States. And then these folks for a long period of time are going to be completely asymptomatic. Their cardiac output is going to be met. But then when they start to have symptoms, they're going to start to display symptoms related to decreased cardiac output. So they're going to have like the exertional kind of symptoms to include shortness of breath with exertion, exertional chest pain because they're not getting that cardiac output and coronary artery blood flow because that perfusion pressure is going to be down. They're going to have exertional dizziness and syncope because you're not perfusing the central nervous system appropriately. And then, of course, heart failure because of that decreased cardiac output. You're going to start to display that, and it's going to start to back up into the atria, into the lungs, into the right side of the heart, and then into the peripheral system as well. With aortic stenosis, the murmur you're going to encounter is this crescendo, decrescendo pattern. Best heard in the aortic auscultation site, so the right upper sternal border, and it tends to radiate to the carotids. The direction of flow is up to the carotid, so you can hear that radiation of that murmur up there. You get this crescendo, decrescendo pattern because, remember, the flow of blood out of your ventricle is an active process, so you start to build that turbulent flow as the pressure starts to increase, rise, and then you reach that peak where now that pressure is going to start to drop off because you just don't really have a volume left in the ventricle to maintain that pressure. So you start to get that drop in pressure, drop in flow, which means a drop in the intensity of that murmur. So that gives you that decrescendo pattern for this. EKG, because the ventricle, the left ventricle is having to work harder to try to open up this valve to get that flow of blood out. You're going to see that left ventricular hypertrophy present. It's going to then work from the ventricle to the atria and cause atrial enlargement. And because of the damage that's being done with these compensatory changes, it could lead to the development of different types of arrhythmias. One in particular is like atrial fibrillation, which is very common in our patients with aortic stenosis. Chest x-ray, you're going to see kind of the chronic changes related to the anatomy of the heart. Echo is going to be your test of choice because you're going to be able to see that resistance to flow, but then you're going to be able to measure how much flow actually is there. You're going to be able to measure the aortic valvular area, and that's important because that will impact treatment options. So how do we treat aortic stenosis? Well, ideally, we can treat like the afterload issues, so we can get that valve to open at a lower pressure, which may be able to do that with like ACE inhibitors because it also helps with reducing that adverse cardiac remodeling that's going to happen with this condition. But ultimately, these folks tend to progress and will need a surgery eventually. And when we have surgery, or when this patient finally qualifies for surgery, at our disposal is this transcatheter aortic valve replacement, or TAVR. So it's a much less invasive type of procedure where basically you take this synthetic heart valve that's kind of collapsed on itself, then you pass it where you want it, you inflate the balloon that it sits on top of, that will deploy the device, and then now you have basically a 3-leaflet synthetic valve in place to replace the diseased valve that was causing the aortic stenosis. And they tend to respond very well and very quickly from the surgery once they get it. One other thing to kind of talk about is when your patient meets the criteria for severe aortic stenosis, you have to start asking them about symptoms experienced. And this is important. If they say, oh, I'm completely asymptomatic, I don't have any problems, go about my day, fine. You have to verify that they are in fact asymptomatic and haven't made lifestyle changes that might make it look like they're asymptomatic. And the importance to that is once symptoms start to develop because of aortic stenosis, that prognosis starts to go down quickly. So if they start getting angina, then they have less than 5 years to live. If they start getting syncope, they have less than 3 years. If they have shortness of breath, they have less than 2 years to live. So verify that your patients with severe aortic stenosis in fact are asymptomatic when they say they don't have any symptoms. Then we went on, we started talking about aortic regurgitation, and again, primary versus secondary causes, and of course, acute versus chronic. So if we are talking about chronic causes, but primary sources, you've got congenital bicuspid valve can cause aortic regurgitation, endocarditis that eats away at the leaflets of the valve, rheumatic heart disease. When we talk about secondary but chronic causes of aortic regurgitation, we're looking at things like aortic aneurysms or aortic dissections where that will pull that valve leaflet of the aortic valve apart and cause the regurgitation. And when we look at the pathophysiology of chronic aortic regurg, the biggest thing is going to be this volume overload, because all that volume that you were able to eject during systole, because of that aortic regurgitation, it's just going to come, most of it's just going to come right back. So what ends up happening is you have a very low diastolic blood pressure because you're not maintaining that volume that was squeezed. But then the heart's going to have to respond with all that extra volume, so it's going to generate an even more powerful squeeze, which is going to cause an increase in the systolic blood pressure. So you just have this widening of your systolic and diastolic pressures, and that leads to this widened pulse pressure, which is a hallmark of chronic aortic regurg. So this would be the difference between systolic and diastolic greater than 40 is concerning for aortic regurgitation. When we talk about causes of acute aortic regurgitation, be thinking of things like infective endocarditis, where you have, instead of an erosion of the leaflet, you now have it where that vegetation kind of interferes with the closing of the valve leaflets and causes that acute presentation. Aortic dissection, where that tearing actually comes down and it affects the valve itself. other trauma, and then iatrogenic, meaning we as medical professionals did it with doing some invasive testing or procedures. And with acute aortic regurg, you're going to have that backflow, so you're going to have that volume, but the pressure is going to increase rapidly, and that increased pressure experienced in the ventricle is going to go to the atria, and now that increased pressure in the atria is going to lead to the lungs. So the hallmark of this is that pulmonary edema. They may have like a flash pulmonary edema associated with acute aortic regurgitation. And then this just kind of shows what we just talked about. So acute, you get that acute pulmonary edema. With chronic, you get that widened pulse pressure. And then there's a lot of other physical exam findings that can be associated with aortic regurgitation. We showed a couple of examples of that in class. And then when we talk about the murmur associated with this, there's a couple of different murmurs. So you have this decrescendo pattern, which is that flow, that pressure differential between the aorta and the ventricle is at its highest at the beginning of diastole, and then as that volume comes down into the left ventricle from the regurgitation, but also because it's coming from the atria, that differential, that pressure differential starts to decrease, and that starts to slow down that turbulent blood flow, which gives you that decrescendo pattern. And this, even though it's an aortic valvular disease, it's best heard at the Erb's point, or the left sternal border, not at the aortic auscultation site. And then there's another murmur that you may hear, which is called an Austin-Flint murmur, which kind of mimics like a mitral stenosis murmur. But this is not a problem with the mitral valve. This is from when you get that regurgitation coming from the aorta, it hits that anterior leaflet and then kind of pushes and closes the mitral valve leaflet a little bit. So now you have an obstruction in the way of blood flowing from the atria and into the ventricle. And then you're going to see the compensatory changes on your EKG. So left ventricular hypertrophy and left atrial enlargement are going to be there. The chest x-ray findings are going to be kind of dependent on if this is acute or if this is chronic. But you may see, like in the acute, you can see that pulmonary congestion. Echo is going to be your test of choice, because you're going to be able to see and measure how bad it is. You'll be able to measure some of the secondary consequences related to it. And then from a medical standpoint, you're going to want to do things like ACE inhibitors or dihydropyridine calcium channel blockers to decrease that afterload so that you can hopefully get more flow out. Beta blockers are questionable because you don't necessarily want to increase that diastolic filling time with it, but you do want the cardiac remodeling effects from beta blockers. So it's kind of questionable, it's kind of controversial using beta blockers in this situation. But the biggest thing you can do is just reduce that afterload to try to improve the forward flow and decrease that backwards flow. And then if they meet the criteria for surgery, then they would just go in and they would get a valve replacement. And similar to aortic stenosis, this is a progressive type of disease. And if they start having symptoms, then the prognosis starts to drop significantly. So if they start developing chest pain, then they get you have about 4 years left to live. If you have heart failure, then you have about 2 years left without doing a surgery to fix the problem. Then we went on, we started talking about the tricuspid valve. We talked about how with tricuspid stenosis, rheumatic heart disease is the most common cause of this. But we also then talked about how tricuspid valve damage is the third most common valvular lesion. So this just shows you that this is not a common condition to encounter. But when you do have tricuspid stenosis, unfortunately the right atria is going to bear the burden of all of that. So it's going to affect the right atria by itself. And unfortunately, that increase in pressure, increase in volume of the right atria is going to then translate to the peripheral venous system. So you're going to have all those right heart failure symptoms of jugular venous distension and peripheral edema. And as far as the symptoms go, we talked about, or as far as physical exam goes, we talked about how you can get a abnormal jugular venous pulsation wave where you get this giant A wave. Remember, the A wave of the pulsation wave is that atrial kick. But if I have an increased volume present and I'm having to generate a higher pressure in order to get that valve to open, get that flow from the right atria to the ventricle, you're going to generate a much higher pressure before you finally get that valve opening and you get that flow into the right ventricle. The murmur with tricuspid stenosis, similar to the mitral stenosis, is going to be this decrescendo-crescendo pattern. Again, you rely on that passive flow initially, and then you get that then you get an active flow with the atrial kick that causes that crescendo pattern. And because this is a tricuspid valve, it's best heard at the tricuspid auscultation site. EKG, you see that right atrial enlargement. Again, this is only affects the right atria, doesn't affect the right ventricle, so you don't get right ventricular hypertrophy with this. But your echocardiogram is going to be your test of choice again, because you're going to be able to measure that and measure the secondary consequences of that. The way we treat it, well, we first got to do the fluid overload, so diuretics and salt restriction, so you get rid of that peripheral edema that's present. But then ultimately, you're going to need to do something to fix the valve, which could be that percutaneous balloon valvotomy that we talked about with the mitral valve, or we may need to go in and actually replace the valve entirely. Then we went on, we started talking about tricuspid regurgitation. We talked about how secondary causes of tricuspid regurgitation are the most common, meaning that the ventricle dilates and that pulls the valve leaflets apart, and that leads to the regurgitation. But there are primary causes, which we've talked about with like infective endocarditis, rheumatic heart disease, papillary rupture, but then there's this carcinoid syndrome, which is a rare GI neuroendocrine tumor that causes serotonin release, causing plaque formation. So that is an entity to add on that we haven't talked about with the other two valvular lesions, or the other two valves. From a pathophysiologic standpoint, with acute tricuspid regurgitation, you're going to have that right atrial dilation, which is then going to lead into affecting the right heart, and it's going to cause right heart failure. So you're going to get the peripheral edema and the jugular venous distension with this. But kind of the hallmark that kind of separates acute tricuspid regurgitation as chronic is you have an adaptation that occurs with the right ventricle. You get that right ventricular hypertrophy because you've given time for the ventricle to try to generate a higher pressure squeeze or stronger squeeze to get that blood out to the pulmonary system. But unfortunately, that just makes the condition worse because you still have that lack of integrity of the tricuspid valve, and you don't get that unidirectional flow. That brings us to 150, so let's go ahead and take 10 minutes and come back and continue on what's over here. We left out talking about our physical exam. We talked about the murmur, but one additional thing that you're going to see with tricuspid regurgitation, if we're looking at that jugular venous pulsation wave, is you get a prominent V wave on the jugular venous pulsation wave. V wave is right towards the beginning of diastole after that aortic valve is closed. But typically, this is a venous filling with the atrium tense, so it's fully it's full. That tricuspid valve is closed, so you're not. You have that atria is really full from all that regurgitant flow coming in, and also all that venous return coming from the peripheral venous system, and it's trying to get rid of that volume and into the ventricle. But so you're going to have this prominent V wave right before that tricuspid valve officially opens, and then you get that flow from the tricuspid valve. or through the tricuspid valve. You're going to have the holosystolic murmur with tricuspid regurgitation. Because remember, the start of S1 is the closure of the tricuspid and the mitral valve. So you're going to have that closure occur, but then you're going to immediately start having that flow of volume from the ventricle and into the atria. So you're going to have that holosystolic murmur. And because it is a tricuspid valve disease, it's going to be best heard in the tricuspid auscultation site. EKG, you're going to see the changes of both the right ventricle and the right atria, but echo is going to be your test of choice because you're going to be able to measure that regurgitation that does occur. From a treatment standpoint, from a medication therapy, the most common cause of tricuspid regurgitation are going to be things that affect like the pulmonary system. So like pulmonary hypertension, maybe even pneumonia, COPD, those types of things. So let's address those conditions if it's a secondary cause. But if it's a primary thing, then we're going to have to treat the symptoms associated with it. So the diuretics to treat the heart failure. From a surgical standpoint, we'll typically go in and do a valve replacement or a repair, depending on what's the cause, but it's going to be an open heart procedure in order to fix that. Then we went on and we started talking about, we finished up talking about the pulmonic valve. We talked about pulmonic stenosis as being a rare condition, and typically we think of this being associated with other congenital abnormalities. So we talked about tetralogy of Fallot has one of the 4 criteria for tetralogy of Fallot is like a pulmonic stenosis, or at least a pulmonic outflow obstruction. But then we also talked about Noonan syndrome, where they have a constellation of symptoms, some physical findings, but one of them is pulmonic stenosis as well. And then we talked about how carcinoid syndrome is also a potential cause of pulmonic stenosis. So you have that GI neuroendocrine tumor secreting serotonin that causes these plaques. With pulmonic stenosis, you have that resistance to opening of the valve. It's going to lead to an increase in the right ventricular pressure, which is then going to lead to right atrial problems, which then is going to lead to heart failure. So you're going to have right-sided heart failure because of this. The treatment, or how are they going to present? Initially, they may be completely asymptomatic, depending on how bad that stenosis is, but this is a progressive disease, so it may, or it's going to progress and get worse, which then means they're going to have to start having symptoms with this, and the severity is only going to get worse. But be thinking of the exertional symptoms because you're not having that forward flow cardiac output leaving the right side going to the lungs and then to the left. But then you also are going to have the backup volume going into the peripheral venous system, so you can have all those heart failure symptoms. The murmur for this, similar to aortic stenosis, is going to be that crescendo, decrescendo pattern again, because of that active squeeze generating that flow. You're going to get that flow increasing over time as you get squeeze, 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 pressure, pressure higher, and then it's going to reach the peak and then start to slow down the flow, which then decreases the intensity of the murmur, and you're going to get that decrescendo pattern. And this is a pulmonic valvular disease, so it's best heard at the pulmonic auscultation site, so the left upper sternal border. Echocardiogram is going to be diagnostic of it. Your EKG, you're going to see that right ventricular hypertrophy. And then the treatments for this can be like the balloon valvuloplasty or valvotomy, but it could also be doing like a valve replacement if they're not a candidate for that or if that doesn't work. Then we finished with talking about pulmonic regurgitation, and we said that with pulmonic regurgitation, the most common cause of it is actually pulmonary hypertension or pulmonary diseases that causes the pressure to increase in the pulmonary circulation. And unfortunately what happens is you get that flow leaving the right ventricle into the pulmonic circulation and it just comes right back. So then you're going to have increased volume, which means increased pressure in the right ventricle, which then is going to lead to the experiencing of right-sided heart failure. And they tend to be asymptomatic for a long period of time until it gets to the point where that regurgitation is just so bad that there is no way to meet that cardiac output that's necessary. So they start having those exertional symptoms associated with this, but then they also, of course, have those right-sided heart failure symptoms as well. And the murmur with a pulmonic regurgitation is this decrescendo pattern, best heard at Erb's point of the left sternal border, exactly like aortic regurgitation. And then when we look at the X-ray, or look at EKG, you're going to see that right ventricular hypertrophy. When we look at X-ray, we may see that right ventricular hypertrophy if it's pronounced enough, but your echocardiogram is going to be your test of choice for it. And patients tend to be asymptomatic related to pulmonic regurgitation until it gets bad enough or it starts to impact the function of the right ventricle. We tend to try to treat it because the most common cause of pulmonic regurgitation is pulmonic disease, i.e. like pulmonic pulmonary hypertension. Then we try to treat those causes first. So let's treat the pulmonary hypertension to see if the pulmonic regurg gets better. If not, then we do have the volume overload concerns that we have to address. But surgery may be an option to go in and replace the valve to correct this condition. Then we moved on and we started talking about heart failure. We talked about how there's a lot of descriptors that can be used to discuss heart failure, where some of the pathophysiologic things of these are similar, but there's, the end result is similar, but the pathophysiology of how we got to that end result are different. So systolic dysfunction, we said, you get ultimately a decreased cardiac output, but that's because you're not emptying the ventricle properly during systole. And that's your heart failure with reduced ejection fraction. When we look at diastolic dysfunction, this is heart failure with preserved ejection fraction. You still have that decreased cardiac output, but it's because you're not filling the ventricle with an adequate volume in the first place. When we talk about left-sided heart failure, what we're talking about is you start having pulmonary symptoms because that left side is not functioning right. When we talk about right-sided, we talk about the peripheral venous edema that you'll see. And then when we talk about low output, we're thinking about cardiac, low output meaning like the cardiac output's low. And then when we talk about high output, this is basically a condition where the heart's functioning because of like an infection or something, increased sympathetic tone, but it cannot keep up with that pace and starts to fail, starts to lose function because it just can't keep up with it. When we talk about systolic dysfunction, or HFrEF, this is the most common cause of heart failure that we're going to experience, and the most common cause of it is coronary arterial disease. But what we might see and what will cause this condition is one of two things. Either you're losing the contractile function of the myocardium, i.e. from like a heart attack that killed myocardial cells, or there's a state where there's an increased afterload. So if you have like a hypertensive emergency, or just a profound elevation of blood pressure, the aortic stenosis, it increases that afterload. So you're having to work harder to generate a more powerful squeeze just to get that aortic valve to open, to get that blood circulating, which then leads to decreased cardiac output. With what ultimately happens with this is because you have that decreased contractility, you're having more volume, more pressure in the ventricle at the end of systole than what you should. Then you add the volume of blood coming from the atria to that already higher volume, higher pressure, which just further increases that. I then increase increase my preload or my end diastolic pressure, which then leads to the left atria starting to have problems because now it has a higher pressure that it has to work against, which then leads to pulmonary congestion from all that fluid extravasating from the pulmonary system. And then from a reduced cardiac output standpoint, because you're not squeezing enough, your stroke volume is dropping, then you start having those exertional kind of symptoms associated with that reduced cardiac output. Then we went on, we started talking about diastolic dysfunction, or HEF, and we talked about how the EF is normal, but we still don't have the cardiac output because we just don't have enough of a volume to generate a reasonable cardiac output to meet our demands. And we talked about that what causes this diastolic filling, or this diastolic filling dysfunction, is you lose a compliance of the left ventricle. Things like left ventricular hypertrophy, restricted cardiomyopathy, fibrosis, those types of things lead to the function, the reduced compliance of the left ventricle, so it doesn't want to fill during diastole. And when we talked about kind of the symptoms associated with this, again, it's going to come down to left-sided heart failure symptoms. So you're going to get that reduced cardiac output symptoms, but you're also going to get that venous, pulmonary venous congestion type of symptoms as well. Left-sided heart failure relates to reduced cardiac output. The same things that cause HFrEF are things that cause a left-sided heart failure. But you also do have things that cause diastolic heart failure. If it's affecting the left side, can cause left-sided heart failure as well. For right-sided, the most common cause of right-sided heart failure is the left side is failing, and it's just causing problems in the lungs, which then causes problems to the right ventricle. But when we look at primary things that affect the right side but don't affect the left, we have to think and consider the pulmonary system for this. So do you have pulmonary hypertension? Is there a large PE? Things that are going to cause a rapid increase in the afterload that the right ventricle has to work against. And then you can also get it where you have increased preload of the right ventricle, where now you're getting kind of an excessive amount. So things like pulmonary regurgitation or tricuspid regurgitation can then cause the right side to fail. And then conditions that cause decreased contractility, think of ischemic heart disease causing that. And then low output failure, so that's just the cardiac output is reduced. But high output failure, think of like infectious or high sympathetic tone, where the heart has to function at a much higher rate to a point where it just can't keep up and it just kind of wears out and starts to fail. Then we talked about how you have the compensatory changes that start to develop in the heart when it starts to fail. And most of these actually have a negative impact on the overall function, because these compensatory changes occur because they think they know what's going on, but it actually doesn't really address the true problem. So there's lots of different systems that have interplay to try to fix the failing heart. We talked about some acute things that can happen that kind of can be changed from beat to beat. And we talked about Frank Starling's mechanism, where as that preload starts to increase, you generate a more powerful squeeze. But that goes to a point where now that preload is excessive, and now you start to reduce the contractility. So you can't just keep throwing more and more preload there and expect that the contractility is going to be able to keep up. There is a point where you break the system. The sympathetic nervous system, it can act by doing either a positive ionotropy, so increasing the contractility of the heart, but it also can do a increased chronotropy, so how many beats per minute you have in the heart. And this can work in that acute setting, but the problem is once you get out of that acute, like it's working just acutely, and now you're expecting it to be chronic, that chronic stimulation leads to a downregulation of the response to the sympathetic nervous system, and so you're not getting the same impact or the same effect that you would if this was just used in the acute setting. Then we talked about how you have the neurohormonal alterations, or the neurohormonal reactions, where in response to different baroreceptors around the body, it's going to trigger a hormonal response. And things like the RAS being activated by increasing renin production, which then triggers all the cascade of the RAS to occur, which ultimately leads to increasing volume retention, which does have the point of increasing the afterload, which is going to that's going to decrease the cardiac output in a diseased heart as it is, but it also increases the preload, which if you already are in a volume overload state, that's going to lead to worsening of the heart failure. And then also the antidiuretic hormone is released from the pituitary gland, and that causes you to retain water, so that increases your volume, which then again in a volume overload state where you have excessive preload, that's going to make the heart failure worse. And a couple of examples of this neurohormonal alterations in addition to the RAS and ADH is endothelin-1, which is a local reaction where the endothelial cells produce this, and it causes a local vasoconstriction. And with the vasoconstriction, that's going to then increase your systemic vascular resistance, which increases your afterload, which then is going to harm the cardiac output. Then we talked about natriuretic peptides and how this is one of the few compensatory changes that we're going to encounter that actually addresses what the problem is and has a positive benefit to the failing heart. So these are released by the stretch of the atria or the ventricle, depending on which version of the natriuretic peptide you're talking about. And ultimately what happens is you shut down the RAS, so you get rid of angiotensin II, you get rid of aldosterone, you inhibit the release of renin. As a byproduct of all of that, you then start to excrete sodium and water instead of retaining it like the RAS wants you to do. You're going to counteract that vasoconstrictor effect of angiotensin II, and you're going to get a vasodilation, and then it also affects the impacts of vasopressin, so now you're not retaining water and sodium like you would normally. So now you're addressing that afterload problem, you're addressing that preload problem to address the failing heart. Other causes, but these are chronic compensatory changes, would be like concentric hypertrophy, and this is typically in the setting of like an excess pressure. So if you have a pressure overload problem, you're going to see concentric hypertrophy, and basically what you're trying to do is to generate a more powerful squeeze with this. When we have a volume overload state, you get eccentric hypertrophy, and this is basically just trying to reduce that stress and strain that's occurring to try to keep the myocardial cells in contact with each other. And ultimately what happens in like HFrEF, where you get that eccentric hypertrophy, you're able to tolerate a larger volume, but you're not generating as powerful of a squeeze, and you can see that pressure loop thing going down and to the right. So you can tolerate a higher preload, but you can't generate a more powerful squeeze, and so what ends up happening is your end systolic volume is going to be much higher than it should normally be, because you're not getting rid of the volume that's there. HFpEF, or the diastolic dysfunction, you're going to get that concentric hypertrophy, so you're going to be able to generate a more powerful squeeze, but unfortunately you're not going to be able to tolerate as high of a preload as you normally should, so what you see then is that pressure loop curve goes up and to the left. So you have ultimately a higher pressure for the smaller the volume that you have in the ventricle, and it quickly rises to the point where now you can't tolerate additional volume without opening the aortic valve, or sorry, closing the mitral valve, and then you open the aortic valve up here. And then we talked about acute decompensated heart failure, where you have these acute symptoms that come on, and there's lots of things that can trigger this acute decompensation, which the little mnemonic or acronym, depending on whatever, heart failed can help with helping you determine the different etiologies that could have caused this acute decompensation. And what you're going to see with the acute decompensation is if you have left-sided heart failure in isolation, you're going to see the pulmonary stuff. So you're going to see the crackles, you're going to see the dyspnea with exertion, you're going to see some chest discomfort, you're going to have the I can't lay flat at night anymore type of symptoms. If you have right-sided isolated symptoms, then you're going to see those peripheral venous symptoms of extremity edema, JVD, abdominal edema, those types of things. But oftentimes, the most common cause of this is this. So you're going to get a mixture in a lot of patients of both left-sided and right-sided heart failure symptoms. So what are you going to see on exam? So if you have a left-sided heart failure, you're going to see a lot of pulmonary kind of things, but ultimately, kind of one of the best things you're going to hear is the crackles on pulmonary auscultation. With right-sided, you're going to see that JVD and that peripheral edema, like you saw on the page before, or the slide before. As far as ancillary studies go, you are going to want to get some laboratory studies, especially like your natriuretic peptides, depending on what your facility uses, because these are important because this will help you differentiate cardiac causes of like shortness of breath compared to pulmonary causes of shortness of breath. So this can help you determine that. We talked about how a probe BNP, there's the normal values are dependent on age, and you can basically just, it doubles every bracket that you go up. So if it's less than 50, anything greater than 450 is abnormal. If you're 50 to 75, then it's anything greater than 900. If you're greater than 75, then it's greater than 1800 is abnormal. Other diagnostic tests you can do, so looking at like a chest x-ray, you're going to see that pulmonary congestion, especially if you have that left-sided heart failure. You may see some enlarged cardiac structures, or even seeing like the pleural effusions if you have like a pretty profound fluid overload state. And then the EKG is not a very good test for this, because there's nothing specific on the EKG that's going to tell you, yes, this is in heart failure or not. It may give you evidence of maybe one of the causes of that acute decompensation, i.e. like they just had a heart attack and they have a STEMI there, or they have an arrhythmia that developed, and that's what's causing that cardiac output to acutely decline. Echo is going to be your test of choice, because you're going to be able to see, is this a diastolic dysfunction or is this a systolic dysfunction? And then we talked about how when you classify heart failure, you have to know what their NYHA is, but you also need to know what their ACC-HA staging is too. And we talked about how the NYHA, this is a functional thing, so what is their function level like? Class 1 is no limitation at all. So their heart failure doesn't limit them. Class 2 is considered mild, and this is a slight limitation where they're comfortable at rest, but ordinary physical activity results in fatigue, palpation, or dyspnea. Class 3 is moderate. This is a marked limitation. They're still comfortable at rest, but less than ordinary activity causes them to have symptoms. And then class 4 is they're unable to carry out any physical activity without having symptoms. So these folks are going to be severely limited on what they do on a day-to-day basis. And then when we talk about HAACC, we talked about how stage A heart failure is anybody who just has risk factors but does not have any structural or functional changes. They just have risk factors for developing heart failure in the future. If they are stage B, heart disease is present, so there's either a structural abnormality or a functional abnormality, but they do not have symptoms yet. Stage C is they have that heart disease that was present on stage B, but now they're having symptoms related to their heart failure. And then stage D is advanced, where basically despite all the medical therapies we have, they still have symptoms. And then we moved on to the management side of it, which again, I'm going to give you the algorithms for heart failure management to reference during the exam. So that includes stage A, stage B, stage C, D, HEF, PEF. Okay? I'm going to be giving you all of those algorithms. So don't spend the time memorizing those algorithms. Just spend the time kind of working with them, applying patient scenarios to them so you can come up with the correct answer. But when you encounter a patient with a new diagnosis of heart failure, you've got to get that echo, because you've got to know exactly what flavor of heart failure you're dealing with. And you can classify your patient if they have an EF of less than or equal to 40, then this is a HEF-REF. If they have mildly reduced ejection fraction, then their EF is between 41 and 49. And then if they have an EF greater than 50, then they have HEF-PEF. And when we go to do treatment, what we're trying to do is let's first identify the cause and correct that. Let's eliminate the acute precipitating cause of the symptom. So do they have an arrhythmia that needs to get addressed? Do they have an infection that needs to get addressed? Let's manage the symptoms of that heart failure. So that would be like the volume overload. Let's treat that. And then let's prevent, kind of long term, let's prevent that adverse cardiac remodeling that occurs so that we can preserve function in your patient. And then of course, prolonging quality and quantity of life. I'll quickly breeze through these because you're going to have these for reference, and we're going to go over this in our lab on Friday. But again, stage A, heart failure, no symptoms, no structural, no functional changes. And the treatments for stage A are just address the things that put them at risk so they don't get worse and start to cause a structural or functional problem to develop in the heart. Stage B, now you have structural or functional problems, but you don't have symptoms. And now with this, we're going to have them on medications to try and preserve function, improve function, so that they don't decline and need more aggressive kind of therapies with it. Which part of that is like doing ACEs or ARBs. And in addition to the antihypertensive components to it, we also get that reduced remodeling. So we're reducing that adverse cardiac remodeling. However, studies have showed that really the benefit for ACE inhibitors and ARBs in patients like this with heart failure is it reduces mortality and it decreases hospitalization. So you get a mortality and hospitalization benefit with ACEs and ARBs. Beta blockers, kind of similar, where you get that mortality benefit associated with the use of beta blockers. But the key thing is you don't want to be starting these medications in the acute decompensated state. So you've got to deal with the volume overload first, and then you can start them on this beta blocker. Then we went on, we started talking about stage C, where now you're having symptoms, and stage D is you don't respond to treatments as adequately or enough. And we talked about there's a stepwise fashion to this. And one of the medications that is highly recommended in somebody with stage C is actually using the angiotensin receptor neprilysin inhibitor, or ARNI, because the neprilysin inhibitor component of it, it inhibits the breakdown of the natriuretic peptides. So now you have higher circulating levels of natriuretic peptides, which means you have more of a positive benefit associated with those peptides being in circulation. And then valsartan, we talked about the benefits already for that. Mineralocorticoid receptor antagonists also carry a mortality benefit and reduced hospitalization benefit. The only thing you have to be careful of is the combination of an ACE and an ARB with the MRA and watching what the potassium levels are doing. But they inhibit the cardiac remodeling that occurs in these patients, so that's how you get that mortality benefit. Then we talk about SGLT2s, and these are even in your non-diabetics. There is a mortality benefit that is associated with these, and I would also add the GLP-1s. New literature has shown GLP-1s are also good for reducing mortality benefit and have basically similar outcomes as the SGLT2 inhibitors do. And then we talked about diuretics, and although we like to think that these are great for our patients, and they are in the sense that they treat those acute symptoms, unfortunately there is no mortality benefit on a long-term basis because this does nothing to address the compensatory adverse cardiac remodeling that occurs in this disease. So this should be reserved just to treat volume overload conditions. Then we talked about how there's a specific population, or there's special populations that may need some additional treatments, and one of those would be in African American patients who don't respond to the initial step 1 regimen. Then we talked about adding like a hydralazine isosarbide dinitrate medication, which works to help with improving morbidity and mortality in African American populations. Then we talked about you have an implantable cardiac cardioverter defibrillator or cardiac defibrillator, where basically it detects an arrhythmia and it will shock the patient's rhythm into a normal rhythm, hopefully, and that there's a certain population where EF gets less than what, 35%, but don't have evidence of left bundle branch block, then you're going to use this. If they do have evidence of a left bundle branch block, not only are you doing the cardiac defibrillator, the ICD part, but you're also doing the cardiac resynchronization therapy part. So you're doing the pacemaker and ICD in one. And you're trying to restore a normal, coordinated squeeze of both the left side and the right side. Then we talked about how if you have you do those things, you've done everything, you've titrated all the medications up, you have them on a good regimen, but they still are not having an improvement in their symptoms, their EF is not improving, then we may need to be aggressive with like the mechanical circulatory support devices like you see here. So a great example of this would be a left ventricular assist device, or LVAD. Other non-pharmacologic things that we can do to make sure our patients with heart failure are optimally managed is making sure they're up to date on their vaccinations. Let's make sure they don't have hypothyroid disease, and then of course let's screen for depression, because that depression can limit their control of their symptoms and their condition. Avoid NSAIDs at all costs because of the renal impairment. It could precipitate a acute decompensation if they are taking NSAIDs other than aspirin. Let's not put them on a calcium channel blocker because, unlike beta blockers, these do not carry a mortality benefit. So you're not kind of risk benefits there. So yes, you slow heart rate down, but you're not getting the positive benefits, the mortality benefits, like you do with beta blockers. Then we moved on, we started talking about HFpEF, and we talked about how there's not a lot of great evidence in HFpEF on treatments that we should be doing and stuff like that. But basically, kind of, when we look at the treatment algorithm, it's really limited to diuretics as necessary or as needed, and then address correctable causes of impaired diastolic function. So let's limit the decline, the further decline of their condition by addressing their hypertension or addressing their valvular disease or whatever is causing that condition to be there in the first place. And then this was just the algorithm for HFpEF. Again, not great evidence from when these guidelines were first published, but hopefully with the more research, we'll have better treatments for our HFpEF patients. Regardless of which flavor of heart failure you have, the prognosis is poor. Most of these are progressive diseases. They're just going to continue to decline. Two main causes of death with patients who have heart failure is that arrhythmia suddenly develops, and then that decompensation or that's the condition gets worse and the pump starts to fail. But most folks, when they're diagnosed, especially if they're symptomatic or they require a hospitalization, usually you have a 50% mortality at 5 years. Then we talked about how we have a patient who is coming in to see you with acute decompensated heart failure. All those treatment algorithms that we talked about aren't really applicable at this moment. So what do we do for that acute patient? First thing you're going to do in the emergency room is you're going to do PAMI, or you're going to put them in position upright. You're going to give them oxygen if their SpO2 is less than 95%. You're going to monitor them, getting labs and RADs and those kinds of things. And then you're going to get IV access, because you're going to be giving them IV medications to treat this condition, because that gut edema is going to affect the absorption of oral medications. And when you have a patient who's presenting with acute decompensated heart failure, they're going to be in one of 4 quadrants, which is going to affect how you treat it. So we talk about volume status, and we have to assign, are they wet, do they have congestion, or are they dry? And then when we talk about perfusion, is it that they are perfusing well and they're warm, or do they have a poor perfusion and their extremities are cold? And combining those 2 values for the 2 categories gives you one of 4 presentations you'll see. And when we look at like the warm and wet patients, so they are perfusing, they're just congested, let's give them a diuretic. Let's get that volume overload off. Let's give them vasodilators to decrease that afterload to improve my cardiac output. If they are cold and dry, so now they are not perfusing, but they're not wet, it's a cardiac output standpoint, or it's a cardiac output issue. Let's make their squeeze stronger by giving them ionotropes, especially if their blood pressure, systolic blood pressure is less than 90. And then once you start to help with that, then you can kind of start to consider the vasodilators to help with that cardiac output by reducing the afterload. But you don't want to necessarily immediately hit them with vasodilators if their systolic is already less than 90, because that's just going to cause it to drop even further. And then when they are presenting as poor perfusion and congested, so they're cold and wet, this has the worst prognosis and outcomes. But now you have a congestion problem and a cardiac output problem. So let's deal with the congestion by giving them a diuretic. Let's give them a ionotrope to try to get a more powerful squeeze to improve my cardiac output. And then as tolerated, once that blood pressure starts to come up, let's start hitting them with the vasodilator to help reduce that afterload and improve that cardiac output. How do we know a patient is wet or they're congested? Well, JDD would be one thing. Crackles on lung exam would be another. If you have anything like the hepatojugular reflex, you've seen that peripheral edema. All of those things are indicative of a congestion. How do we know that you have low perfusion? Well, the blood pressure being low is one. The cold extremities is another. If you're seeing cyanosis, that's just showing you that you're not circulating blood properly. All of those things can be indicative of somebody with low perfusion, low cardiac output. And then we talked about how with the diuretics and the treatments, this would be the, in your fluid overload state, your diuretics are going to be used to get rid of that volume overload. And you have the loop diuretics, which are probably the ones we use most commonly. But there are some thiazide like diuretics that you could use as well. And typically we usually use those as add-on or adjunctive therapies. But there is no mortality, chronic, long-term mortality benefit associated with these. When we talk about ionotropes to use, the two options we have are going to be your dobutamine and your milrinone. And both of these work pretty well at helping increase that contractility. You may want to consider using milrinone if they are on a beta blocker already. Either one could work. You just may get a better response to milrinone if they're taking a beta blocker. And then other things that you have at your disposal, especially if they are cold and wet, so volume overloaded and poor perfusion, then hemodialysis or hemofiltration is an option for you because it will get rid of that volume overload and hopefully restore the cardiac output to a reasonable level. You do have the mechanical circulatory support devices that you can use as well, so like an intra-aortic balloon pump or an LVAD. But ultimately, especially if they're not responding to treatments, then these folks may need a heart transplant because the pump itself has failed. But there are certain things to kind of factor in based on your recommendation for treatments for your patients. And maybe, the discussion for palliative care, hospice care may be better for your patient. And things that might portend to a worse prognosis is their age. Are they going to be able to live through invasive procedures? Do they have organ damage of other organs than just the heart? Because if they have a liver that's failing, they have a kidney that's failing, or whatever, then probably not going to recover from doing an invasive procedure to address the heart issues. Okay. Let's go ahead and stop there for the day. We'll tackle the rest during the lab portion on Friday.